Hello, hello. Welcome to the last workshop of the day. If y'all need to get up and shake it out a little bit, go ahead. I know I needed to, especially after the last workshop that was just in here. If you were in here, Donna's got the most soothing voice ever. So good afternoon. Welcome to the 7th Annual Pathways to Hope Conference. This workshop is the Pandemic and Recovery from Substance Use. My name is Christy Alsagar, and I will be your workshop moderator. Before we get started, we have a few housekeeping items, which you guys have heard all throughout the workshops. It's probably getting a little annoying, but we have to do it. Before we get started, if you are attending the conference to receive CEUs, please listen carefully. All registered attendees seeking CEUs must remain in the session for the entire duration, must have signed in with the proctor, must obtain an evaluation form from proctor prior to the start of the session. At the end of the session, you will need to check back in with the proctor to turn in your completed evaluation to receive your certificate. Each workshop session is approximately 75 minutes long. You will receive 1.25 CEUs for this session. These are issued to LPC, LMFT, social workers, and psychologists. Each attendee can qualify for a total of 3.75 CEU today for attending all 3 workshops. We are grateful to have the support of NAMI Texas and the Bexar County Recast Project for making these CEUs available. Again, all registered attendees seeking CEUs must remain in the session for the entire duration. Upon completion, when you turn in your evaluation form, you will receive your certificate. And I want to say a special thank you to Sacred, San Antonio's Community Resource Directory. They are taping all of these workshops, so if you want to see ones that you missed earlier today, they will be online. And now it is my pleasure to introduce our speakers. Evita Morin is an LMSW, has been honored to serve Rise Recovery since 2016. Her civic and nonprofit career spans the front lines of civil service, housing, educational, and addiction treatment. A San Antonio native, she grew up throughout urban and rural Texas before attending undergraduate and graduate school at Columbia University in New York. Passionate about her community, she also proudly serves as a board member of Master's Leadership Program of Greater San Antonio, the Blood and Tissue Foundation, and her HOA. She is the recipient of recognition by San Antonio Women Magazine as a San Antonio role model, the SA Business Journal's 40 Under 40, and NASW's Alamo Region Social Worker of the Year. She has 2 beautiful children, and she loves camping with her family across Texas. Evita Morin. David Phipps is the president and CEO of Lifetime Recovery, a nonprofit behavioral health organization providing mental health and substance use disorder treatment for the underserved of South Texas since 1963. He has been with Lifetime Recovery since 2012. After serving 7 years as the executive director of the Christian Dental Clinic at Haven for Hope, leading both organizations in growth strategies with major facilities renovations and capital campaigns. He has more than 35 years of executive management experience in both for-profit and not-for-profit healthcare organizations. Prior to his nonprofit career, he was vice president and general manager of Hope Medical Supply in San Antonio and Corpus Christi. He served in the Air Force at Wilford Hall Medical Center, Lackland Air Force Base. He holds an MBA in Healthcare Administration with Our Lady of the Lake University and a bachelor's degree in Communication and Public Relations from UTSA. He has been active in the community serving on nonprofit boards for healthcare and musical arts organizations. He served as secretary, treasurer, and board member for the Nonprofit Council. He served with other agency heads on the City-County Joint Opioid Task Force, which brought funding and programming to our community for battling the opioid crisis. He is the first vice president of the Association of Substance Abuse Program, a Texas-wide 501c4 advocacy group for prevention and treatment providers and mental health organizations. Lifetime Recovery is a 501c3 organization accredited by the Commission on the Accreditation of Rehabilitation Facilities, a United Way partner, and Platinum Level Guide Star agency. David is married to Amory Dameron Phipps, and he enjoys sailing, choral singing, and 3 wonderful grandchildren. David Phipps. Lisa Jensen has served in the San Antonio community for 35 years as a mental health professional and community service advocate. She is the CEO of Alpha Home, a 47-bed residential treatment facility for women struggling with alcohol and addictions. Prior to joining Alpha Home, she has worked in the hospital administration for over 17 years in the psychiatric and addiction field. Lisa is the licensed LMSW clinical social worker. Lisa Jensen. Enjoy the show.
Okay, well, thank you all for being here. What a wonderful conference and what a wonderful thing that San Antonio is doing. And we want to congratulate NAMI and the other groups that put this together. And thank you all for having us here. We think that substance abuse and substance use disorders and things are a component part of mental health, and often hidden in the conversation. And one thing I would like to bring out today is how what we're trying to do is open up that conversation, make it a topic that is not shameful, and when people can ask for help, that they get help. All of our organizations are helping people who are have trouble accessing care. Maybe that they don't have insurance, they don't have money, or don't have transportation, whatever. We work very hard in the San Antonio community to be sure that those who are underserved, medically, that do not have any resources, no insurance, have a pathway to treatment, as well as prevention and recovery support services. So this continuum of care that we represent up here is very important, and I think a fundamental component to the mental health community. So we're thrilled to be here, and we're just going to kind of chat, and then we'll open it up for questions. As we said, Lifetime Recovery has been here since 1963. We started with kind of a handshake deal to have use of the property out at South End Road, which used to be the old boys' school, juvenile boys' school home. So it was always a residential type facility. It was, it just wasn't used for a few years. So a couple of old Southside AA guys, I mean old, not old, but old, got together and they shook hands with the County Commissioner Blair Reeves, and they said, yeah, you can use the property. Come along in 2012, there was the need to formalize that relationship, and so there was a license to operate. And then since then, we've negotiated with the county for the use of that property for the next 40 years. So we're excited about that. So that means that we're going to be a component part for the community, for Bexar County and South Texas for quite a while to come. So we're there for the indigent client. We're there for those who can't seek service anywhere else. And part of the problem is if you can't seek service, then you're going to isolate, stay at home. It's going to get worse. And we saw that with COVID, and we'll talk about that soon.
Hi, good afternoon, and I echo Dave's sentiments on thanking the conference presenters, and I'm really glad you're here because number one, it's the end of the day, and I'm sure you've had a lot of education and exciting things happen. Again, my name is Lisa Jensen. I'm an LCSW board certified social worker and very proud to be representing Alpha Home today. And as mentioned in the intro, Alpha Home is a women's addiction treatment recovery program. And Alpha Home has been around in the San Antonio community for 56 years, and we kind of have a unique way that we got founded. Those of you that are familiar with Trinity Baptist Church, 56 years ago, Buckner Fanning was the senior minister there. And he had a woman in his congregation by the name of Huleen Dempsey, and she was kind of a woman after my own heart. She was providing treatment for 3 women out of her own pocket. And she went up to Pastor Fanning and said, you know what, mission just isn't in foreign countries. We've got mission in our backyard. And there's not enough services for women and addiction that need treatment. So she began stalking him and stalking the board members of Trinity Baptist. And if you think about 56 years ago, at least at my church, most of the board members were male. And so the whole concept of providing women's treatment and recovery in alcohol was formed. And shortly thereafter, Alpha Home became a 50c3 nonprofit, and we still enjoy blessings from Trinity Baptist Church. In fact, I thought I saw Pastor Les Holland walking around here today. And so Alpha Home has been blessed to partner with Trinity Baptist. Not only do they support us as allowing us renting space from their campus, but they also have part of our board members are for Trinity Baptist. And so our roots were founded first faith-based, first that recovery is a mission, and second, to provide a treatment curriculum that is comprehensive so that the women can go back to becoming productive members of society. And so, one of the things that we're going to be talking about is the pandemic, and in just a minute I'm going to kind of talk about what the need is, but I'll turn it over to my colleague Evita. But know that I'm thrilled to be here, and I think we're all passionate about talking about addiction, so when we wrap up at 8 p.m. tonight, we'll have learned a lot.
Hi, good afternoon, everybody. My name is Evita Morin. Oh, hi, guys. I love you. I've been around the nonprofit sector all of my life. It's all I know. And Haven for Hope, where I was initially when I moved back home to San Antonio, is where I spent a lot of my time. And after serving people in their 40s, 50s, and 60s who made these baby steps of progress that were momentous to them, but almost unnoticeable to the outside world, I recognized that so much of their lives, their trauma or their neglect or their exposure to drugs and alcohol started in their childhood. Every time that I spoke to somebody that I worked with. And as a result of that, I was very drawn to Rise Recovery, where I work now. What we do is serve youth and young adults who are experiencing the negative impact of drugs and alcohol and their families. And what I love about that work is that I get to be ahead of, if possible, not everybody, but we try and prevent that first felony, prevent that dropping out of high school, prevent that overdose, and do those things that the holes that these individuals at Haven for Hope have dug for themselves for so long. If we can stop that in the childhood and actually pay attention to those kids before they reach their 30s, 40s, 50s, then maybe they have a chance at getting themselves out of that hole. And that's why I do the work that I do. There is another reason. I am also, and what I love about Pathways is it is about consumers and it's about peer work. There's so much of that in the mission of what's being trained and workshopped here. I am a consumer myself. I am in mental health recovery. I am, this little pill right here. This is my most important. It's a chill pill. I try to take that every day. But I do rely on psychiatry and counseling for my own mental well-being and health. And I'm proud to be able to say that in addition to being a mental health professional, because sometimes that matters even more to the people we're talking to. And so what's unique about Rise Recovery, in addition to it being a ministry, it was born out of Christ Episcopal Church. Reverend McNaughton at the time brought this from Houston so that we could have a space for teens recovering from drug and alcohol use. But what's unique about it is that everybody in our program is in recovery themselves. Many of them were teenagers in our program at one point, sometimes forced to be there, and over time found their place, found their recovery, found their home, and now are employed with us. Many of our board members are people, parents and partners and loved ones who have loved someone in recovery or have lost someone to addiction. And so the purpose that they bring to the table every day is the reason that I get to get up every morning and have the dream job that I have, is that the people that work the front lines and the people who are leading the agency are so invested in the work because they feel it in their bones and they know it in their personal lives. And so all the work we do is at no charge to participants, or at a sliding scale, up to $0 depending on the income. And we've been able to provide community-based peer support, and so that's support groups, one-on-one peer coaching, and now finally a recovery high school, the first of its kind in San Antonio. Thank you. We're so proud of that. And I was just walking over the kids today while they were taking a break. We have about 20 enrolled, and there are more on the way because they find a haven there, and there's hope for them there, and we are attentive to the fact that they're in recovery, and if they relapse, we connect them to help. We don't just discard them and send them to suspensions and leave them alone, which is the last thing they need. And so with that, I think it's time to talk about the pandemic and what that has done, what it continues to do, and what tools we can provide to you all to help you support the people that you love who are struggling.
Thank you. So I want to start kind of pre-COVID and talk about the need, why we're here. And there's two things that I want to share with you. I don't know about you guys, but I'm a little bit competitive, and I like when I'm playing games to be first. That's something to be really proud of. But what I want to tell you about is something that is absolutely shameful in our community. And I just want to give you a couple of statistics pre-COVID, and then we're going to talk about how bad things are during COVID. Number one, this particular data comes from the Health Data National Organization, and it has to do with liver disease mortality. The national average for females is 12. The Texas average is 14. The Bexar County average is 18. Okay, we are number one in liver disease mortality in females for the state of Texas. For males, it is national 22, Texas 27, for men in San Antonio 37. Okay. We win the shameful prize of having the most mortality in the state of Texas. Let me give you another one in terms of this. When it comes to binge drinking nationally for females, and this data is from 2015, it's 12. For Texas, it's 10. For San Antonio females, it's 13. For men in national, it's 24. Texas is 24. San Antonio is 27.8. Okay. Now, I actually have about 40 of that statistics, and I could literally take the time to go through all of them. But I want you to know, when you hear things that more neonatal babies are born addicted in San Antonio than any place else in Texas, that's not something to be proud of. It's not fun being number one with those statistics. And we could take a look at mortality, we could take a look at binge drinking, we could take a look at the percentage of adults who use alcohol, we could take a look at opioid deaths. It doesn't matter, we've got a problem in San Antonio. And in my opinion, even before COVID came around in 2020, we had an addiction epidemic in San Antonio. And the national statistics report that. And so I guess what I'm trying to do is paint the picture for you is that it was pretty bad pre-COVID. The second thing that I want to tell you about is that one of the things that has made our jobs much harder is the concept of stigma. There is this belief that's a myth out there that so you deserve what you get, you brought it on yourself. But what they don't realize is that there are vets with PTSD and injuries that have to take painkillers. There are females that are stage 4 cancer and their doctors are giving them opioids faster than they can take them. One of my colleagues actually was up to 400 pills a day in terms of the medication. And so what I want to present is that the concept of addiction doesn't discriminate. Yes, there are people that do use, but there's an equal amount of people that self-medicate because they've got pain or they're in cancer treatment or they have injured themselves and they become addicted, and that's what causes the national opioid addiction. So I wanted to kind of put the context in place for you so that when we're talking, you can kind of see it was pretty bad pre-COVID, but currently with COVID, it's a lot worse than what we've ever seen. And so I'm going to hand it over to my colleagues so that they can kind of talk about the impact on substance use with COVID, and then I'll do my part.
Interestingly enough, when COVID hit, we were actually doing very well in our outpatient services. We built it up quite a bit, and far greater than it had ever been in Lifetime. We were full to the gills at our residential center, licensed for 94 beds. We were always close to the 94-bed count. And so there was an interesting effect of COVID. When the county and the city first decided to do the shutdown, lockdown, whatever you want to call it, we were having 70, 80 people a day coming through our outpatient for their treatment services. Within 2 days, nobody came. Nobody was riding the bus. Most of our people came to us from, they had to ride the bus. The buses were slowing down. We went from that number of people, and outpatient for us is the name of the game is participation. They can be enrolled, and if they don't show up, how can we help, right? So that was a devastating blow, and we were like, what on earth are we going to do? I mean, we would have 25 or 30 people we would have to lay off. Counselors, care coordinators, direct care people, whatever we've got, they'd have to go. Interestingly enough, the state gave us a waiver on the use of telehealth and telemedicine in order to provide at least contact and at least a counselor with a one-on-one. And then eventually, in the month or so later, we were able to do the groups via telehealth or Zoom or whatever. We've all gotten kind of used to Zoom. I'm still on mute most of the time. When I start talking, I'm kind of surprised I didn't do it here today. But it was a lifesaver, actually, not only for our organization, but what about the people that needed help? What were they going to do? Because what happened when the city shut down, well, then people went into isolation. We saw within weeks statistics of like 64% increase in alcohol sales in liquor stores. Well, why was that? Well, people are drinking more. No, they're not going to restaurants. So they're drinking just as much as they are, but they're drinking more at home. And so we have to kind of go through that statistic and say, oh my goodness, this is really hurting. The stress of being home, we all went through it. I mean, those of us that have to go home. And then we had the additional stress of our residential facility having to stay open. Because what happened is the need went up. The request for beds went up. And we didn't shut down, ever. There were 6 agencies in Texas that completely shut down. How horrible. What would have happened in Bexar County if either Alpha Home or Rise or Lifetime had to shut down for COVID? It would have been devastating because there was no care. We did reduce the number of beds so we could spread them out, and then we had to get staff. Do you want to come in person? We gave them, if you don't want to come in person, fine, you can work from home. But counselors and direct care people in recovery facilities had to be in person. What was another interesting thing about being in our residential center is it's a 45 to 90-day program. Perfect. They're quarantined, except for the new ones coming in. So we had to figure out how to test, how do we do all this, and we all had to do this. So we were scrambling around every day, making decisions, trying to figure out how to handle this. The whole world was doing it, but Lifetime Recovery was doing it, and none of us were sleeping at night. We were talking about stress. And I'm in recovery, but, you know, I didn't use anything during this period, so that's good. But the whole effect of that immediate shutdown was that we had an increase in need, an increase in demand, a decrease in capacity. That was the worst possible thing. So, fast forward a few months, it kind of stabilized. We all were wearing our masks, doing our thing. And outpatient ballooned, doubled, almost tripled. We went from 120 people in our census to almost 400. Many of those were coming from CPS referrals. What was happening there? The dynamic of being stuck at home was having an effect on families, on children, on family abuse, violence, all that. Increased substance use. And it was related to that. So that was where we had to juggle, and that's where we gave bonuses to people so they'd come to work. We gave time off if they couldn't come to work. We gave time off if their children were not in school. You know, all this kind of stuff. And every bit of that caused stress. Stress on the organization, stress on our staff, stress on our individuals, and to say nothing of the clients that we were trying to help.
So at Rise Recovery, the pandemic, what the pandemic has done for young people is kind of split between two paths. When all the kids went home, there was this impression or assumption that these kids were now sort of idle hands and are going to get themselves in trouble. And that maybe for some of that population, they didn't have the support they needed at home. And so their risks did go up. For the other side, they were coming home to supportive, resourced families, and their quality of life actually improved. And so we saw two different kinds of experiences for kids. What's really important around youth is that their brains are still very much developing. And so doing work with young people in recovery has less to do with whether or not drugs are bad and more to do with not messing up the development of a brain that is still growing. It is too early. And one of the little known facts about what creates the highest risk for drug substance use disorder is how early you start. If you started when you're 11, 12, 13, the chances of you becoming addicted is so much higher. And that risk is increased so much more than all the other factors that you think about, you know, trauma and dysfunctional family and divorce or whatever that is, whatever the socioeconomic issues. It's really when your brain starts experiencing that drug or that alcohol. And so what happened during the pandemic, as you mentioned, was that people brought their alcohol inside. And so you've got kids at home, you've got now a whole bar at home, and you've got parents who are coping with the insanity that is the pandemic by drinking. And so that created a cycle of witnessing behaviors that were supposed to be coping skills, but were probably not the best behaviors to be mimicking for these kids. And so that really was one of my biggest worries coming into the pandemic and getting out of it was our kids have seen their parents in probably the most stressful situation in their lives and coping in a way that was socially promoted. If anyone had a Facebook or Instagram account, the amount of memes about toilet paper and booze in your fridge were outrageous. And yet, there are so many other coping skills that we could have employed, that we could have used as an opportunity to teach our kids this is how you handle tough things. And a lot of them were limited. They couldn't go outside. They couldn't do the things that they used to. So it required a lot of creativity. The people that were connected to a recovery community, what I heard from sort of my observations and the people that we spoke to at Rise were the people that had a community tended to, and had recovery under their belt, tended to be okay through the pandemic. One, they've been through hell and back, and they know what it's like to survive, and so this kind of turned on a lot of the tools that they already knew how to use. But for people who didn't have a recovery community, they struggle so much more and were that much more isolated and that much more abandoned. When we rely heavily on the referrals from school systems, usually the disciplinary system. I have such a problem with the disciplinary system disciplining kids, just disciplining them if they are under the influence of alcohol or drugs, because if I had a suicidal outcry, you're not going to send me to an alternative school. You're going to connect me to services or talk to my family or get an intervention. But if I'm struggling with drug or alcohol abuse, I'm going to be kicked out of the school. And the chances of you supporting me through help is not very likely. And so that's been a real challenge. And we rely on the schools to know about us, to refer to us, and to use us as an alternative to just suspending a kid. And when the pandemic happened, the referrals just stopped. There was nothing. And the reason for that is that they were so focused on just trying to find those kids. There was no behavioral interventions, no observation of how these kids were doing at all. So we really lost a lot of our kids, and that's not because they got better and they were, behaving better. They were struggling alone. And so when the schools opened up, that's really when we were able to re-engage. One of the big impacts that now I see, and I'm sure that's a topic in this week's seminars, is telehealth. We were able to go online and reach people who couldn't find us through transportation or through other means. We were able to reach people not just in Bexar County, but across Texas as a result of that. And so there are rural areas in our state that have zero resources, and now they have access to youth recovery support because of the advances that we were able to make in telehealth technology. It is still a very new model, but we all know what it's like to be in a, well, maybe, I know I've used telehealth at some point in my life, and I'm talking to a doctor, but the problem with that is that that's not the same as peer work. Peer work is much more relational. It's much more about developing relationship and rapport and trust and guiding someone through their personal lives. And it's very hard to do that in a telehealth setting. So RISE is really trying to innovate and to find a way, and that's maybe one of the opportunities that grew out of the pandemic, to create tele-peer support that is effective in rural areas and areas that don't have anything. And part of our vision with that is to create their own natural communities of peers within their community, and then develop them into peer recovery support specialists and teach them how to help themselves. But a little more on that later. I wanted to toss this back to Lisa.
Thank you. So, in case you really didn't get it, David has residential recovery for men, and I have adult men, and I have residential recovery for women. And of course, Evita takes care of the young adults and the adolescents. One of the things that was extremely difficult, as I shared with you a little bit earlier, just how bad it was pre-pandemic, and David commented on exactly what started happening during the early pandemic. We started seeing parents working from home, kids not in school, transportation and isolation protocols being in place. And what we saw at the home was increase in domestic violence, increase in CPS reporting, increase in overdose because of that. And so what we saw was a fragile network of recovery treatment being stressed to capacity and then completely shut down. And when we started, we never closed our door at the home like other agencies, stayed open during the entire time, even when we were shut down, because we believe so strongly that we needed to be able to have somebody who said, I want recovery, I want treatment now, to walk into our doors. So we kept our doors open. And so it was really important for us to try and do what we could do with an epidemic that was increasing with need with the same amount of resources, and trying to make some adjustment. If you're not familiar with residential, you live in a structured environment 24 hours, usually from 70 to 90 days, and it's in a group environment. You get about 10 hours per week of counseling, and some of that has to be one-to-one counseling. You get about 10 groups a week, and those are 2-hour groups. And you get about 10 hours of relapse education, like what are my triggers? And so our programs are intense, and so the people that come to treatment with us are getting a lot of recovery, education, counseling, and treatment so that they can effectively be engaged in continuing their growth and their recovery. One of the things that I did recently is I was reading a JAMA article, and it was talking about why people drop out of addiction treatment. And the number 2 things that the clients reported is that they did not have relational or family support. And the second thing was that they didn't have support of their counselor. Well, what did the pandemic cause? It caused that we weren't connected anymore unless you were able to do the Zoom connection. And so that was really hard for a lot of people in recovery. And so God bless Zoom is all I've got to say, is because that literally saved the life of a lot of people. And so one of the things that we do is we all have a recovery coach, and a recovery coach is a peer support person who has gone through certification to turn around and be, like Evita was saying, a living, breathing role model that, you know what, I had an addiction problem, but I'm sober now, and I'm giving back, and I'm here to tell you that it can be done because I'm proof that sobriety can happen. And so some of the things that we've been working on are trying to meet the need with the resources and use some of the skill sets that we have to increase them.
Yeah, I think that this is something that's very important, and each have touched on it and very eloquently. The recovery coaching model is fairly new, and it's been embraced by the state of Texas with some funding. Bexar County is recognizing it as a legitimate way to handle the ongoing need after treatment. What could have happened 10 years ago is someone might come to Lifetime, they would be admitted for up to 90 days, let's say. Maybe somebody might do more than 90 days, but then after that there was nothing. There may have been a tiny little outpatient facility, which we had, but there were very few people in it. So and I'm not going to talk about commercial insurance or whatever, but you know, you're lucky to get 28 days paid for. So 28 days, 45 days, 70 days, 90 days, and we're done. Adios. Good luck. And we had one thing that we had to report to the state, and that was someone sober still after 90 days following treatment? Well, that was pretty easy target, actually. But the main thing that recovery coaching has brought to this is to allow us to stay in contact with someone who's gone through our program for up to 2 years, you know, and that means calling them, getting with them, going to Starbucks, have you gone to the dentist? Have you gone to, you've joined a church, are you going to church? You know, just, it's not a sponsor like an AA sponsor, it's not a counselor, it's not a, it's not your mother, but it's somebody who is a peer, and especially if there's an opioid recovery coach, they have been through opioid addiction, and that's very important too now, because it's a little different than alcohol, obviously. But that recovery coaching system, we all have coaches now. We didn't have them 2 years ago, or maybe you had them because you were leading in this, but we didn't have them 2 or 3 years ago, and so this is an exciting new thing. And actually, our counselors love it because they can stay in touch as well. But here's the deal: if we let them go, and they're not connected to a recovery community somehow, there are 500 sober living beds around town here. I don't know if anybody knows that, but if you leave treatment, you can go to a sober living community of 8 or 10 people. Usually it's only men or only women, and you can live up for 2 years. There's an organization that's one of our partners, Pay It Forward, will help pay for the first 2 weeks of their rent and the like at an Oxford home or a sober living home. But our coaches can stay in touch with them there, and our coaches are actually helping feed these homes. So not only is somebody getting a sober living home, they're connected with the recovery community. They're not going to be homeless, because a lot of people come to us that are homeless. And they're not back into the old slippery places where all those little druggies were, or those neighborhoods where they used to drink. You know, they're being protected in the community. And if you can make it through that first year, odds are those years will add up. My personal story, I'm now 29 years sober. And I don't do that for applause, I don't say that for applause, but I say that because I got connected with the recovery community. I was actually raised, this is a faith organization, faith seminar, so I'll say I was actually raised in a very strict, fundamental Christian home. My father was a preacher, so I was a preacher's kid. I had one brother, he was the good preacher's kid, and I was the bad preacher's kid. So anyway, it just was not in my, this was going to happen to me no matter what. And my blessed mother, bless her heart, she said, well, if you just kept going to church, you wouldn't have gotten in trouble. And I said, Mom, I'm sorry, but I showed up to church drunk. So, you know, and now through the spiritual aspects of recovery, I was able to connect with a spiritual home and that I love and I am communicating with. But what happened is stayed connected with that community, stayed connected, and it worked. So staying connected, staying in communication, and opening up the conversation. I'll say one more thing and I'll pass it to Mike. When I first, I did go to AA. When I first joined AA, I called my parents and I said, well, this is what I'm doing. And that's when the conversation was, well, if you just kept going to church. And what happened was, I thought I was the only one in the whole family. I thought I was in a family of teetotalers, and I was. Nobody. And then it started the conversation. It started opening up, peeling the onion, as we say. Mom said, well, you know, your grandfather beat your grandmother, and he would gamble away the rent money. And he worked for Ford Motor Company for 40 years in Detroit. He didn't ever lose his job. But boy, it was hell at home. And I didn't know that. He said, well, my uncle died of alcoholism. I didn't know that. His son was an American airline pilot who shot himself because they took him off the plane because he was drunk. You know, I didn't know that. My whole family, these alcoholics started coming out of the woodwork in my family because we started getting honest, and I started talking about it and started getting honest. Earlier today we heard about starting a movement and talking about the conversation. You know, the stigma that we're talking about with mental health and substance use, the stigma is very strong with alcohol because, well, you should know better, right? You should be able to control it. The problem now with the drugs that are on the street now, especially if they're laced with fentanyl, we won't get them. They won't make it to treatment. They won't make it past the ambulance. You know, luckily, Cicada and many other groups are providing Narcan so that maybe something can happen, but sometimes that's not even strong enough. So this has gotten way worse, way quicker. And so, anyway, I'm going on too long, but opening up the conversation, staying connected with the recovery community. This high school thing is huge. It is absolutely huge. Because if they go to Evita's high school, they won't come to my treatment center. They won't come. Thank you. Sorry, I got my
Questions? Questions? Oh, Kylie.
Yes. I wasn't prepared, but okay. No.
Any questions? Yes?
Yeah, I was wondering, there's a lot of
There is a microphone.
Yeah,
There's a mic right there.
right here in the middle. I was just wondering, there's a lot of recovery centers, and especially for opiates, there's been a long thought about no medication and so on, but there's a whole lot of help that can be given with naltrexone. which is an antagonist for opiates. So I was just wondering, because I know some of the centers, I don't know about particularly yours, but I do know about the other ones, that they do not allow people to take those medications. So I was just curious about that.
So the good news, and what an amazing question, because it's very timely. If you look at the research today, best practice actually for addiction is a combination of medication-assisted treatment and counseling. The people who have, according to the research, have the most successful recovery are those individuals who engage in treatment longer than a year, counseling, and those people connected to their community, and those people that are on some sort of medication-assisted treatment. Currently, the UT Medical School has 2 programs. One medication-assisted treatment is for opioids, and the second one is for alcohol use disorder. And for those of you that are familiar in the mental health community with psychotropics, you'll know that especially with psychosis, that you can get one injectable once a month instead of fighting somebody to take their pill every single day. And so right now, Alpha Home is going to be working with the medical school here with a alcohol use disorder injectable. So instead of taking the antabuse every day, you get an injection, and for 30 days you try and drink something, you're going to be sicker than a dog. And so that's really important, because that is one of the things that is gaining more traction. It's now being recognized, and there's even a lot of myths around that. Like somebody might say, oh, you're using that, you're not really off drugs, clean and sober. And we have to really take a look at those type of myths, because the truth of the matter is one size doesn't fit all. And you know what, there are some people that can go to AA and get clean and sober on their own, but there's other people that doesn't work for them. And we're all about, number one, acceptance, starting where the client is at, and then finding an individualized treatment plan that works with them. And so using the recovery coaches, using whatever is in our toolkit, because recovery matters. So excellent question. Thank you for asking that.
Yes, and I'm sure I won't go on too long, so that there are other questions. The question is actually well documented, because it was just a few years ago, maybe 3 or 4 or 5, that our board at Lifetime Recovery, we had a retreat, and to learn about this, because Lifetime was an abstinence-only organization. You're right, you couldn't come into Lifetime if you were. Now we support MAT. We don't provide it, but if someone is on MAT, we transport them to wherever their clinic is, or whoever's providing that for them. And let me tell you, that was a big fight in our board, because it was like, wait a minute, that same notion, that paradigm shift is exactly right. That same notion is that, wait a minute, you're just going to be cycling through the same old stuff. But what happens is, if you're doing abstinence only with certain drugs or whatever, it's actually deadly and detrimental. So I'm not a psychiatrist, or I'm not a clinical person, I'm a nonprofit executive. So, but on the other hand, I saw where we've got to help people in whatever pathway they have. Not that we don't recommend this, that, or the other, but our programs have to expand to more than just one way, because that one way doesn't work for all people.
I also, just on that topic, what I have found in conversations around MAT is that the conversation around what works for adolescents is still missing. When you're talking about minors, do the same things work? And I usually get crickets, because more work needs to be done to pay attention to that population. And so I just want to make a note that there still needs to be more conversations. And so when I find myself in a mental health space, I find often, if we're not there, then substance use isn't being talked about, and it needs to be. And if we are in an addiction space, oftentimes youth aren't being talked about, and they need to be. So we have to be everywhere to make sure that we're representing the populations we serve, because so much of it starts then. And if we're wanting to stop this epidemic, then we have to start where they start.
there any other questions? Yes, ma'am.
What is the difference between the traditional 12 steps sponsor and the coach?
Excellent question. So if you think about a sponsor is there to work with you. Are you having triggers? What are your triggers? Are you going to be relapsing? And they're doing that intervention related to it. A recovery coach is, I don't want to use the word caseworker because that talks about kind of social workers, but a recovery coach is to do whatever it is you need. So if you're trying to be sober, but you have some difficulty paying your light bill, and you want to, complete an application for a deferred, reduced light bill, guess what? A recovery coach will meet you there. They will go to Walmart and meet you. They will go wherever it is, and they will be your advocate to help you do, some people call it the social determinants of health, the kind of the day-to-day stuff. I make a joke about being a hospital administrator in recovery because for 37 years I was a hospital administrator, and I would have people get out of the psych hospital or the addiction unit and they didn't know how to go get groceries. They didn't know how to shop. They didn't know how to cook because the addiction, their life revolved around that addiction. The recovery coach is there to stand by your side so that they can help you work through whatever it is that needs to have happen.
Well, the sponsor will just take you through steps 1 through 12 and be sure that you're utilizing the steps to your life change. And the coach, in my mind, is to help you overcome obstacles to staying in recovery. And usually coaches will not be acting as a sponsor or using the steps. They may be in recovery themselves and be working the steps on their own, but their job is not to go through the steps with that person. It's just as Lisa said, if something's tripping me up, oh, I don't have enough money to go get this tooth pulled. I keep talking about that because I used to run a dental clinic. But, what happens is you get discouraged and you go, well, there's nothing I can do about it, and I'm in pain, and here we go. So it's overcoming those obstacles. That's what the peer coach is really.
I have been in mental health pushing 50 years, and almost every one of my patients has said I started drinking and drugging in high school or junior high or earlier, okay? Well, where I work, we get tested for COVID twice a week, and I was just thinking, maybe it's high time that we prepared a home testing kit for families, and we got proactive with parents watching their kids and testing. It doesn't have to be on, every Monday, but it can be, kind of like we do in nursing with our recovery nurses. They call this 800 number, and if it says go in for a P test, you go in for a P test. If they don't go, you don't go. But I was thinking, if we're going to stop this thing of drinking and drugging in junior high and high school, there's got to be some kind of monitoring. And I grew up with the Ozzie and Harriet situation, and I would hope that parents would buy into something like that. Literally, if they got to get home testing kits or something like that to stop it, nip it in the bud, as Don Knotts used to say.
I completely agree with you. It's so interesting. I just had a similar epiphany when I was planning my kid's next physical. And I thought, my goodness, how awesome would it be if at every time that I had to take my kid for a physical, they would drug test him or her. Just so I know, and that everything is, just normalize it, and so a lot of times we talk about how that physical is such a standard. Why aren't we assessing our kids with a drug and alcohol questionnaire in the same regular way? And maybe you won't be surprised, but I think I'd be surprised how honest kids are if you just ask them, and how open they would be for help if you just offered it. But a lot of times we don't want to. We're afraid to tell them, especially if they've got addiction in the family. I'm amazed at how many parents tell me that they didn't want to let their kids know because they feared they were opening Pandora's box, and that somehow was going to turn on the switch for them to become addicted themselves, when that's probably the most important information you can give a kid is, hey, this runs in our family. This is a genetic predisposition. You have to be more careful than your average person because you have substance use in your family. And if we were able to normalize those conversations, to normalize drug testing whenever we would do any other kind of physical examination, to normalize asking the question when we ask anything else, then I think that would resolve a lot before it gets too late.
Ronald Reagan said, trust with verification.
That's right. And you know, if you stop and think about it, the disparity between what the schools do, screening for eyes, screening for your spine curvature, but they don't do the screening for mental health and substance abuse. And the data shows that the co-occurring of both mental health and substance use is very high. And so, but again, it goes back to a lot of the stigma. They don't want to talk about mental health, depression, or any of those issues. They don't want to talk about addiction. But unless there's that type of change to normalize it and it make it okay to say, then we continue to deal with some of these things.
Let me tell you, I've been reporting 5 days a week. Schizophrenia, heroin, bipolar, methamphetamine, alcohol. I mean, you get the mental health diagnosis and the substance abuse diagnosis with 99% of the inpatient.
Thank you, sir. That is exactly right, and that's why we're here today, to keep talking. But we want to have that linkage because it's there. And if it's not being diagnosed because of some billing code or something, then, we've got to look at that too.
At least they could be diagnosed by starting to ask questions. Let's just start there.
Yeah, I wanted to say something about that, which is very important. I think when you have very young kids, you can pretty much tell if they have an extreme level of anxiety, or in your family, if there's a lot of mental disorder. So it's a really good thing to talk about it. And also there's a lot of fear about medication when they're young, which I totally understand. But when you have somebody that has a severe problem like sensorial processing disorder or general anxiety, if you don't address those issues when they get a little bit older into the teenage years, it can become a problem. But there's other tests that can be done, which I really don't understand why the medical community is not doing that. You can have a GARD test which allows you to tell very clearly what substance somebody is chemically predisposed to be more addicted to, and if some of your receptors are not working. And those tests are done. They're expensive, but they cannot be expensive if the doctor prescribes them, which is the same reason also that, and I'm again not a doctor, but these tests also help to better select medication if they're trying to give you medication for any type of mental disorder. Unfortunately, the doctors don't like to use it for some strange reason. So.
I agree with you completely. I actually had genetic testing done, and because I have a very high tolerance, and I had a huge slip and fall with 7 surgeries in 2000, and there was not a single pain medication that worked for me. And so my primary care suggested that I get genetic testing, and it turns out that genetically, I could take opiates and it doesn't do a thing for me. And so in my medical condition, they had to figure out what they could do, so when I'm having a C-section that, I could not scream all the time. And so you're absolutely right. There is enough genetic testing out there to take a look at what is hereditary, what can be passed on. And like Evita was talking about, that if our family's predisposed to addiction, then we need to have those conversations. So you're absolutely right. Other questions? Yes, ma'am.
Does all 3 of y'all's places take mental health, drug, and alcohol? Because some places just take alcohol, some places just take mental, and some places just take drugs.
I'll speak for myself and then I'll pass it over. So how we do our treatment is that we will take people who are co-occurring, meaning mental health and substance abuse, but the mental health cannot be primary. And so if it is primary, we want that individual to go get some treatment, get stabilized on psychotropics, They have to be able to participate, so we do have to have the alcohol to be primary, but we do take co-occurring.
I think it's unavoidable. You have to, I mean, if you're working with people who need recovery, then they're probably recovering from other things, mental health, trauma. And so, but what the benefit of peers is that we can still, we don't just work, we know our lane. Our lane is substance use, and the peers we have on staff are people who are specifically in recovery from substance use. They may have mental health disorders as well, or in recovery from mental health, but that their certification is on how to address substance use. And so what they do is they recognize that a person is more than just one issue. A lot of times there are multiple things going on, and a peer support can assess that and then direct that person to whatever other care resources are needed and walk with them, literally walk with them to those waiting rooms, to those appointments, to those meetings, to those support groups, so that we know they get there. And so you need multiple resources. I think most of us do, to resolve the issues that around mental health and substance use. But I also want to recognize that is one of the biggest problems in behavioral health system is, if I've injured my arm, I can go to Text Med, I can go to Urgent Med, I can go to Santa Rosa, I can go just about anywhere to get it resolved. I may pay more or less, but with behavioral health, you don't even know where to start. You may be the wrong age, you may be using the wrong drug you don't even know what you need. And the resources are so siloed and so limited, and so few offer recovery from everything that it's incredibly disappointing, and it's incredibly discouraging for people who are finally ready to get help. So what we've done, the three of us, is pull together a helpline, and it's run from morning to evening and on weekends. And the whole purpose of that is to be, one, a warm line for a human being to answer the phone when you're calling, and for us to hear what are the specifics of your situation, what is your age, what is your drug, what is the reason that you need help, and then we can give you a list of targeted resources that address those specific needs. And that's really the only way that we can help our community get better at that, until our community gets better at being any door is the right door. We're not there yet.
Those are great answers.
Yes, so, is it on? Yeah, so you mentioned sober living facilities, about 500 or so in the city.
Sober housing.
Sober live, yeah, and so what are y'all recommending for those that do have mental illness and substance abuse, both? Because I haven't really found many, if any, that will take someone with that.
So you're talking specifically about sober living? There are some mental health group homes that are out there that function similar. How the sober living works is that when somebody has completed their recovery program, as David was mentioning, they can go into sober housing, and the sober housing perspective helps focus them on trying to find a job and maintaining their sobriety and support of that. But there are some mental health group, is it Family Endeavors? I'm thinking it's Family Endeavors that has some psychiatric group homes that are out there. And so those are available as well. Does that answer your question?
Yes, or how about any outside the city that you recommend?
Actually, on the mental health group homes, I don't know very many outside of the city. I'm more familiar on the mental health side, but the NAMI may be able to give you some resources in that area. You look on their website, but the one that I can think of off the top of my head for group home living is Family Endeavors, has some resources.
There's also, I think, a directory of something called the Oxford Homes, and I'm not sure what the range of those are, but I know they're Texas-wide. There's more support for them lately, so there probably are some that are outside of the city. The 500 that I know about are within the city. They're not all Oxford Homes. They're usually independently run, and they're managed by people in recovery. And if one is in that home, they have to keep and retain a job and also maintain their sobriety. Otherwise, they can't stay there. So that means they may come back to Lifetime or go back to alcohol, so we hope. But that's the whole purpose of that. I'm not sure there's one that's going to be just exclusively mental health and substance abuse, but there may be people that are in these sober living homes that are on medication and being helped by the mental health community.
Yeah, so I just want to say that there are privately run housing situations where there's sober homes. I happen to run one of them. I'm opening up a couple more, but we do take people with co-occurring disorders, and there are trained peers that are running these places. They're trained in mental health. Most of them have substance abuse diagnosis also, so it's not something that you have to worry about. As long as you are staying on your medication and you're doing your program, everything should be fine.
Thank you for sharing that. And the other thing about RSS coaching is that a lot of the RSS peer recovery coaches now are being required to take mental health first aid, specifically because of the amount of co-occurring that's out there. Other questions?
I was wondering, what is the phone number, the helpline that you mentioned?
210-SAY-CARE, SAYCARE. Whatever numbers are associated with that. 210-SAY-CARE, SAYCARE. You're welcome.
And the good thing about that is that this helpline is run by people that are in recovery, as opposed to just calling a helpline and talking to somebody who doesn't have that lived experience. And so that's another thing that's really important about this. And one of the reasons that it was formed is that we wanted to make sure there was an opportunity for people in recovery to reach out to somebody who knew the recovery community and also had the training to be able to understand some of the challenges with that. Other questions?
Hi, I work with UIW Nami on campus, and we did an event not too long ago. It's called Give Us a Pizza in Your Mind, because college kids love food. But we did a bunch of mental health screenings and substance abuse screenings, and we found that a bunch of students reported binge drinking over the weekends. So my question is, how do I best help my peers with that?
What a great question. Number one, thank you for going and doing those surveys. The few times where I did NAMI on campus programs, that was one of the things that came up. So part of it is education-based with it, and then being able to open the conversation with it. I think it's one of those things that, what's the saying? You can lead a horse to water, but you can't make it drink, and the job is to convince them they look thirsty. And I think that's kind of the challenge with it, because people cope with different ways. And so for many people, looking at the binge drinking is coping because school's so hard and so stressful. And so having those conversations about being able to look at self-care differently, and being able to have those conversations. And if you ever struggle with something like that, reach out to any one of us. I mean, that's right up Evita's alley with young adults, and it certainly is an opportunity to get somebody that is in treatment, been there, done that, to have some of those conversations.
Yeah, I'll also say that that's one of the other challenging myths to overcome for people with substance use issues, is that binge drinking is not a problem because they stop in between for days at a time, therefore they can control it. Really big myth. And so helping people understand that binge drinking is in fact a problem, or could be a problem, does have a negative consequence or negative effect on their health, or whatever it is that they, whatever the consequences they experience, is a good first step. The second is the collegiate recovery programs. There are more and more growing, and if you don't have one on your campus, creating one is another incredible first step. Just like in high school, where there's little to no concept of recovery, the same applies for colleges. A lot of times, there's little to no concept of recovery, and people actively choosing abstinence from drug and alcohol and supporting one another from it. So creating collegiate recovery programs is another great way that student leaders can help change the campus and start planting seeds for students to realize that there is an alternative way.
Any last questions? We are at the end of today's session. We really appreciate you sharing space with us today and coming to this workshop. There is sacred.org if you would like to find resources near you for yourself or a loved one with mental health issues. And Bridges to Care is glad to train anybody in companionship.
There's some business cards on the front if anyone needs them. Thank you so much for your time.